Good afternoon, everybody. Welcome to the fourth in our series of webinars on what's happening with the pandemic, COVID-19, and the public trust, conversations with leaders from all over the region. My name is Michael DeWilde. I'm at the Seidman College of Business at Grand Valley State University. I want to thank the Dean's Office at Seidman, as well as the Koeze Family Foundation for helping to support these webinars. Today, we are talking to two of my favorite people to talk to. I'm very glad that they could join us. Dr. Leslie Jurecko, who is a pediatrician and until recently was Senior Vice President of Quality and Safety at Spectrum Health here in Grand Rapids. In the last 2 weeks has moved to Ohio, where she takes on that same role as Chief Safety and Quality Officer at the Cleveland Clinic in Ohio. Also a graduate of the Executive MBA program at Seidman. Dr. Alejandro Quiroga, he is also a graduate of the EMBA program, a nephrologist by training, and he currently serves as Senior Vice President for Population Health at Spectrum Health. Thank you both really for taking time to join us. I know how busy you are. I appreciate it.
Thanks for having us, Michael.
Yeah. I want to start just by asking both of you maybe to give us a current state snapshot from your perspective. Obviously we read and hear an awful lot about the course of the pandemic, treatments, possible vaccinations, all kinds of things. Give us a sense of where you think we are right now. Leslie, do you want to start with that?
Sure. Yeah, thanks, Michael, and glad to join Alejandro. So current state, I think we know a little bit more. I heard an interesting line today by one of our leaders here. It said, we need more time because as the pandemic keeps going, we keep learning more. And that's really how it's been, but there's still a lot of unknowns. I think one of the things we're doing right now, current state, is as we're watching across the United States kind of uprising, and what this means going into the fall with flu season, I think that's got many of us worried. We're watching numbers out of Australia and what they're starting to see on both of those viruses and how they might collide. It's looking fairly positive, so that makes me happy to know that, but I think that's one of our bigger concerns right now is just the state of the country on the rise going into the fall.
Okay, thanks. Alejandro?
Yeah, thanks for having me, and nice to see you, Leslie. Wish you best luck in your new endeavors. We'll certainly miss you already. I would like to say, I think like our current state is just a lot of confusion. And the chaos is palpable, the confusion is palpable, that we have messages that are dissimilar, that are not aligned, in a time where we don't have, like Leslie said, enough information or make really great decisions, which has magnified the degree of confusion. It is a very sad reality, and at the same time, it's very hopeful to see how a lot of different healthcare systems, a lot of different organizations have risen to fill some of those voids, some of those voices, and have helped us lead through some of this chaos.
Good, thanks. Well, let me follow up on that then, if you don't mind. So one of the things that you read, of course, that the response to this virus has revealed a healthcare system that is quote unquote broken. I don't know that that's true or not. Spectrum Health is the largest healthcare system in our region. Cleveland Clinic, of course, world renowned. Do either one of you share that perspective? And if so, what do you think that means? When people say this has revealed a broken healthcare system in the US, is there validity to that? How would you respond to that?
I'll take the first stab, Alejandro. So I think it's not a healthcare system in general. I think it's healthcare across public health and the delivery of healthcare in healthcare systems. I think it just shed a lens on all of the areas we had to learn, that where we didn't know we had opportunity. I think we'll probably get to unpack some of the disparities later or throughout this hour together, but I don't think it's just healthcare systems. I think it's public health, healthcare systems, communities, all of us together is really not broken, but there's certainly opportunities where things could have been probably prepared for. We knew one of these pandemics was likely going to come. We knew one of these viruses would break through. We never knew when. Obviously, it's been 100 years since the last one, but there probably could have been more preparation looking back.
There's certainly areas for opportunity, and I think like the differentiation that Leslie makes is something along the lines that I will agree with, right? I mean, it's what's public health versus a healthcare system, right? And a healthcare system playing and we're constrained by our legislative rules and what the name of the game has been for healthcare in the U.S. So those two differentiations are very important, and it's just how do we go about it? And one thing that is important is that where we get paid and we are good at delivering care for very sick people. So that aspect of the healthcare system is not broken, and the epidemic has shown that our own experience, and that's a very important differentiation.
As you're both having that conversation at your respective institutions, what kind of ideas are being floated to begin to prepare better for either events like this in the future or other things where you should
be preparing for the fall? Really looking at what zip codes, and I'm sure in Michigan and in Cleveland, we're both doing this, looking at what zip codes are at highest risk and really pulling data out of those zip codes on areas we can help. It's really been interesting in certain areas, certain cities, certain zip codes, on the ability to do that well. And so I think as we prepare for the fall and, hopefully not another virus to break through, but it's really how do we set up systems that support those areas.
Politicize this quickly or at all, but nonetheless, is that something that healthcare systems can do more or less on their own, or do you need to work hand in hand with policymakers who understand what you're up against and at the very least don't
without all of those important people at the table? So that's been helpful. I also think healthcare systems in general have worked across boundaries. You've seen that in Grand Rapids and West Michigan, healthcare systems working together with the health department. And the same thing is happening here in
partnerships have been highlighted by this current pandemic, and getting better at that, forcing collaboration with other healthcare systems is going to be crucial as well. It is just interesting that we have competition in healthcare, right? It is important, I guess, where
which providers get incentivized. Are there certain kinds of incentives that the population might respond better to as well? Are there things that you need to educate us about, or maybe even manipulate us to do better than we're doing to stem?
And right now, it is just not everybody can see 5 years ahead. Not everybody can think about a lot of those things that we're doing on a daily basis with our eating habits, lack of exercise, and also be inviting. Right? Being a doctor has been, in my tenure as a doctor, it's been very interesting how the conversation has evolved, right? From the beginning, I mean, I'm a subspecialist. I train to see very sick people. I'm good at that. Is that what's right for the community? Sure, you want to have that skill set in the community, but how can we reframe the conversation to make sure that you don't need those type of services? So we're thinking constantly about how can we be more inviting and not telling you what to do. Certainly will never work for me to tell you that you need to exercise. And
it's an interesting time in March to try to figure out. We pivoted very quickly, and I can speak for both healthcare systems to start an incident command or command center. And we had guiding principles around that command center, really supporting the patients in our community. And that was Spectrum Health's goal, was how do we keep the community in Grand Rapids across the system that would help. And we brought a lot of diverse thought to those groups. And I'm sure Alejandro could speak to the ambulatory one really well, to really problem solve and get the work done. One thing I loved about what we did in this crisis management time is we had pretty much everybody drop their titles at the door. When we walked into these different meetings, it didn't matter what, if you were a chief or an individual contributor, you had a role to play, because we needed all hands on deck to prepare. So that was the first kind of week. Alejandro, you want to talk about the ambulatory camp a little bit?
Well, it was interesting, right? I mean, this is a large organization that, it won't be no surprise to anybody that we suffer from some of the things that any large organization would suffer, and that we, as leaders, will have desires to make things more nimble, to flatten the structure, as Leslie mentioned. And it was just interesting how it happened so fast. Things got nimble. People were putting the community first, which is something that we do on a daily basis, but it was just a selfless act. You can see people leaving their families with their spouses, stay at home, and putting endless hours of heavy duty work to stand up humongous processes that it would have taken us months to stand up before. And there was a lot of learnings from that. It's just, I remember looking around the room in one of those camps, that it was one of the camps that I was helping lead, the ambulatory camp, and thinking, wow. But it was impressive. It was just impressive to see what people can do, what people, when we have a common goal and the sense of urgency was shared, how the throughput was so different and so impressive.
Is there a possibility of that being a double-edged sword? Are you taking care of frontline providers? It seems to me that we're asking, at least over time, an almost impossible task of at least some of them.
Yeah, now I'll say that I got a very disturbing text message today from one of my vice presidents just saying, hey, we need a break. We've been working so hard for so long, and it is, we need to make sure that there's no new initiative, that there's new project, that there's nothing new that we can add. And I will been reflecting of that all day, because it also, I mean, it certainly feels like failure on my end. And so what you bring as a question is a very important thing for us to continue to reflect. And it's not that it has been on my rearview mirror or like that it has been a blind spot. We've been very deliberate to make sure that people have time off. We're actually have mandated in many areas, like you need to take time off now. We have shift people around. We're definitely trying our best, but at the same time, there's a non-stopping sense of urgency and fly of new information with new problems, and doesn't seem to go down. So we're having to be very careful about that, and more purposeful for sure. So I am certainly worried about that.
Yeah, I'll add with the front line, I remember thinking, watching our teams come in the early morning hours every day, and they're the ones really running into the fire. And at the beginning, it was so important to do what our community did so well, because we didn't have enough PPE. No organization had enough PPE or protective equipment at that point in time. We certainly ended up being fine in West Michigan, which was great at the beginning, but there was so much uncertainty, and we were changing all the time because CDC was changing, and other societies were telling us, wear this mask, do this, wear this shield. And so the constant change and the unknown early on were really tough. Now we're in a better spot with PPE. Thankfully, we are in a much better spot with PPE. So I think we're ready. I think still we're learning about this virus. So what kind of masks do we wear? In what environment? What kind of face shields do we wear? So we're adding more of that now. So our poor frontline caregivers are still getting changing messages as we learn about this virus, both globally and locally. And it's just constant. And I'm sure they're looking back going, was I protected those 20 other times I took care of that patient? Because now you're telling me to wear a face shield. And now you're telling me to wear this type of mask. So I'm just cognizant of the constant change, and that I think is wearing on folks.
And I'm going to ask you about the ethical questions as well. So I became first aware of it in Italy, where emergency rooms were overrun, and then in New York City, now in Houston, in Florida, those places. Did you have conversations in Spectrum about what might constitute futile care, and who would receive treatment and who didn't? And was that a new conversation? Not in the sense of, you never had it before, but new, at least in the context, excuse me, of this emergency?
Yeah, absolutely. That absolutely new. I look back and there was a couple really challenging situations we were in. I mean, so many, but one was stopping visitors from visiting their families. And the second one, and equally as hard, was this discussion around allocation of resources. When you talk about ethics, it is as deep as you can get with ethical decisions when you're talking about allocations of resources. I would say the beauty of how we approached it is not just took a multidisciplinary team with it at Spectrum Health, but we really went state and national wide and compared what we were thinking with the Ann Arbors, the Detroits, the Clevelands. Everybody worked together to say, yes, we all have a different environment, different numbers of cases, but how would you approach this? Because we couldn't go at that one alone. The decisions were way too tough.
And along those lines, are there things that you wish the public knew more about or informed itself more about in terms of, again,
severe acute respiratory syndrome. And, a few years back, we were all terrorized that this could come and cause like very severe disease. And maybe just by naming the SARS virus, people would have been taking this a bit more serious. That's one of the things that I think I wish we can reframe. Just tell people, this is SARS. Remember SARS? You were scared of SARS. And it's interesting how the conversation has become so political in the country when there are real health implications. I know the real economic implications, and I don't have the answer to all of those really difficult questions, but certainly I would love for us to come together and like at least appreciate the catastrophe that we're suffering and really try to help each other through this period of trauma and how can we overcome it.
Great. Thanks, Alejandro. So to that end, I'm reading into that you support the governor's actions here in Michigan in terms of continuing social distancing, mask wearing. I take your point about maybe framing it in terms where people would have taken it more seriously earlier on. Is there, well, maybe you can help us with this. So the WHO, the CDC, and now the Department of Health and Human Services are all involved in this. They've all come in for criticism of one kind as well as praise. There was an article yesterday suggesting that the White House has asked reporting agencies to bypass the CDC and report directly to the Department of Health and Human Services. Do either one of you know more about that? Maybe can inform us in terms of what that might mean, what the implications are, why is the CDC coming in for criticism, et cetera?
That's a very difficult question. I mean, I don't have insight into that, but I will say to the governor that, I mean, like any decision made by anybody, right? At points I've been in like great agreement and like thrown a lot of praise to the governor, and then some decisions that I've been like, wow, I mean, where's the information coming from? But in general, I think that the decisions are well informed, really well intended, and difficult. And I think that's the appreciation that we have to have for these decisions. The best leaders that have responded to this crisis across the world have put their own personal gains aside, and that's very palpable. So, there's places like New Zealand that have done amazing in terms of their response. And sure, it's a smaller country, but there is a sense of cohesion in the country, and now people actually can go into restaurants, and the overall mortality can be counted. There's 20 people who died in New Zealand altogether from this. So, I mean, these are tough decisions, and we all need to put our ego aside and make sure that we make the most difficult decisions of our careers in our lifetime, for sure.
Yeah, thanks. Leslie, can you weigh in on the CDC?
Yeah, I don't have insight. My assumption would be, the data is really challenging in this. What seems like should be simple data, positive, negative, mortality data, they live, they didn't, is not as simple, at least the inputs. We learned quite early on that just connecting our inputs into a single source across the country was actually really cumbersome and hard. So, most healthcare systems right now are still having at least one person, if not many, input their data on a daily basis from their lab and from their clinical care. So I'm guessing it's a little bit knowing the data and wanting that, the truth around the data. And I think what Alejandro was alluding to is trust. You have seen countries that have really had formal trust in their government and their leaders really come together and respond to this pandemic very well. So when they're asked to put on masks, everyone puts on masks. When they're asked to social distance, people social distance. And I think we've seen that play out globally.
And as you're looking at things right now, are you seeing hopeful signs either on the vaccine front, the therapeutic front? You're seeing that's all hopeful for you?
Yeah, I'll comment, Alejandro, and then you can add. What I'm seeing, definitely hopeful on a vaccine. And what I love about the approach is that we're not just doing it with one or two companies. It's many people are trying to create this vaccine, which ultimately will give us an opportunity to have, I'm sure, a couple, but at least hopefully get approval on the first couple, hopefully this year. That would be ideal, but I'm not sure on the timing.
You're just going to wait and see what happens and allow your immune system to deal with it. And what that means is we don't have great fix for most viral conditions. And this being a virus is not different. And the best treatment that we have had for dealing with viral diseases have been vaccinations. So definitely that's where we should put a lot of our efforts. And the government has allocated a great amount of resources to that, which is great. And we will likely have a vaccine that will be available to the public beginning of the year of 2021. And it is a very interesting way because the development of these vaccines is a complete different methodology than in the way any other vaccines have done in the past many decades that since we have vaccinations. So I'm excited about that. I don't foresee us having great therapeutics for the virus. I do foresee our teams learning to deal with the acute respiratory distress syndrome and the lung injury and the multi-organ failure better. And we've already seen that in our teams here. When you talk with intensivists, they're like, yeah, the first few weeks were horrible. We just didn't know what to deal with. And like now they understand better when to put you in mechanical ventilation, better methods for delivering oxygenation, the steroid treatment when you have a severe disease to deal with like the response from the immune system, plasma therapy, all of those things combined is just the knowledge and the expertise, the skill set is definitely getting better, but the answer is going to come from the vaccine.
Sure. And do you mind giving us a short science lesson on the development of vaccines? Because I think there are a lot of questions, right, about how quickly this is being developed. Do you expect that if it's available as early as January or February, that there's still going to be a certain amount of trial and error? Are there some trade-offs being made in terms of, well, let's do this on a voluntary basis with consent and see how it goes? Or how do you think that's going to play out?
So vaccines are always a very interesting topic because, I mean, an easy example is the influenza vaccine. So every year there is a guess about the type of strain of influenza that is going to be more prevalent, and there's a vaccine designed towards this. And there's a bit of a hit or miss. So some years the vaccine is great, and 80% of people develop an immune response and is protective. And there are some years when we have seen, very low rates of protection from the vaccine, which is not ideal. So there's some guessing, like everything. This is not perfect. The current vaccines, the methodology that they're using. So before, most vaccines have been developed by you having a virus that is either alive but won't cause the disease, and you inject it into people so your immune system learns how to deal with it without giving you the condition, or parts of the virus or a dead virus that you then expose your immune system to, and then your immune system learns how to deal with this. That's been, in a nutshell, how most vaccines have been developed. This time, what we're doing, well, we is a big thing, but what scientists are doing right now is injecting a molecule that is called RNA. And so making this not too complicated, DNA turns into RNA, RNA turns into proteins. Most things that we have in biological systems are proteins, right? Like that's the dead virus that we will inject you for your immune system to learn will be a protein. So you can now, technology has gotten so good that you can now inject either DNA or RNA, which is what the DNA turns into, like it's kind of like the signal that then turns into proteins. You can inject that RNA into people. Your cells will uptake that RNA and create proteins that are like the same proteins that the virus will have that will then teach your immune system how to deal with that virus. That is like an amazing technology. And it's going to come with its shortfalls because this has not been done at this scale before. There's a lot of unknowns, but it's very promising. And since its inception, probably 10 years ago, this type of technology, it was conceived as is going to be one of our best tools to respond to a type of pandemic like this one. And sure enough,
the title was The Future of Healthcare. From the vantage point of your time at Spectrum and now Cleveland Clinic, people are talking about increased use of telemedicine, perhaps different kinds of training for physicians and frontline providers. Again, allocation of resources, going back to that conversation. What are you thinking about in terms of the future of healthcare? And I know that's a huge question, but I'll take whatever angle you want from that.
Yeah, I think Alejandro mentioned earlier that we quickly learned how to be in a virtual environment, and I think it was just once the technology kinks were worked out. So I don't think that's going away. I don't know if it'll be 50%, but I think it'll be anywhere from 25 to 50% of our visits will likely remain virtual in the future. I think we'll be smart about doing things. I think this disrupted us in so many ways. You know, we always wanted to be like Amazon. We're so far away from that, but I think it's going to challenge us to start delivering care where the patient's at versus where we're at. So that's exciting. It's actually really exciting for patients and their families because hopefully they'll seek care when they need it, and it'll be easier for them. They won't have to wait, and they won't have to go through the hurdles they often go through.
Does that provide some promise then too in terms of reaching demographics that, as Alejandro was saying earlier, are oftentimes missed, that this is one way to both make your model more efficient and more responsive, but also have its reach be much greater than it was before? Yeah,
I think so. Access is, you know, a safety issue. It's a quality issue for sure. If members can't get in, extended hours, when we think about some lifestyles, some people work 2 jobs, being able to extend our hours with virtual care is much better than the 8 to 5 model we've usually had in historical medicine. So I'm excited about that. I think we have to make sure that our different communities have the technology and the internet that they need to actually truly interface with us in that. And sometimes I think we make that assumption that they do, and not always do they. So yeah, I think there's a lot of opportunities. It's not perfect yet. We're still seeing disparities play out in our COVID data right now. Certainly our testing, it's hard to get to some of the communities with testing, as I mentioned before. And so we're working on areas where we can move our testing sites to areas where our patients can reach us easily.
And I can't resist this tying question, and take it as you will. But as you know, an awful lot of commentary on the numbers of people who have lost healthcare because of being tied to employment in this country. Mm-hmm. And then people without access in the first place. From your point of view as healthcare providers, as you're talking about that greater reach, would a more European model or Canadian model, something close to universal healthcare where people aren't going to lose it, would that aid in what you're talking about? I mean, again, risking politicizing it, but I'm curious what you think.
Sure. Yeah. I mean, I think coverage in general, absolutely. What would aid right now, we're already seeing a shift from commercial to the governmental payers already. We've seen that in the first couple months, not unexpected. And I guarantee that'll continue to go up, that shift away from commercial to governmental payers. So we have some of that happening. I think coverage in general, whatever the payment program is that we set up, we have to, as Alejandro mentioned, very regulatory. We have to be able to continue to cover virtual visits as we did when we were in the pandemic and have been doing. So we have to open up the gates on some of the restrictions that we've had to reach the populations that we need to reach.
So, I mean, like, you started with how healthcare is going to look, and then you ask about the payment models. And I actually, that is my answer to what healthcare is going to look in the future. It's just we have to continue to think about the incentives. If you think about like healthcare systems, we get paid to deliver sick care. We don't get paid to deliver preventive care. At least, certainly, we get paid a fraction of that, but that's not what gets paid as a bulk, right? And what I hope it really changed is, first of all, that everybody has healthcare. It is still a disaster that healthcare is one of the leading causes, health utilization is one of the leading causes of bankruptcy in this country, that most people cannot afford healthcare. Those things are crimes. That just, and this is a very apolitical statement. I don't know who the answer is. It has to be fiscally responsible, but people need to be able to access healthcare. And getting sick should not be a death sentence in the sense that you will survive your condition, but then, you know, you're bankrupt and you sometimes regret and have some guilt of surviving this. And I have numerous stories to tell. Having an integrated healthcare system brings some opportunity to the table that are very exciting. An integrated healthcare system is a delivery care system, which is hospitals and clinics and doctors, and a payer. So Priority Health and Spectrum Health are the same thing. And in the past, we have not aligned those two things to utilize them better, meaning you can utilize the money that you have from premium for caring of our population and say, how are we gonna spend this money? Well, we can wait until someone has a heart attack and we can spend thousands of dollars in paying for great care for them. We will the same way. So we will have a limited amount of money to take care of the population, and if we do a good job, we'll keep the money. If we don't do a good job, we will spend a lot of money, and that's a shift. And I will foresee that a lot of healthcare systems will have to go more into that direction. Hopefully, that's one of the most important things that come out of this.
Good, thanks. Let me follow up on so that comment from somebody who's listening who knows a fair bit about healthcare. I think you're talking about unintended consequences. You know, the things that come out of incentives that you didn't, of course, foresee or didn't want to have happen. In terms of your own finances, Spectrum Health or the Cleveland Clinic, so much of that, is it correct to say, has been dependent upon elective surgery? And the comment is, does it reveal how broken the system is that hospitals across the country all of a sudden found themselves in dire financial straits when elective surgeries or elective procedures started to dry up? Is that an indication that the financial model is broken? Leslie?
I think it's an early indication that we need to move to exactly what Alejandro was just describing, is pay for a population, for care for a population. It was very interesting and not surprising when we stopped electives that we would have financial difficulty, but it's also hard to control your cost in a situation like that. So when you turn something off, you can't just take away staff right away. It doesn't work that well, and we want to take care of our teams both in Grand Rapids and in Cleveland. So we tried to keep our teams as we could whole. So our cost structure stayed pretty much the same as we turned off the inlet or our revenue stream. So that was just I mean, if anybody, you know, in any business that would happen. And we weren't able to be as nimble with our costs because we knew we had to be ready to have staff in case we had that surge of pandemic or of COVID patients. So it wasn't like we could close business. We had to keep our staff. We lost our revenue, and we had to be ready to turn on for the surge. But yes, I think it opens us up to opportunities to look at our payment models and say, we could do something better. Why is all our money tied up in elective surgeries? Can we spread this out? Can it be more on the preventative side? Those conversations are definitely happening. It's going to take the whole country to do that together, though. All the payers need to go together on that.
And to go to the preventative question again, Alejandro, I don't want to link the two exactly, but you said earlier you don't want to be in a position to manipulate me or to lecture me about eating better or doing more exercise.
Well, I was talking about the population. I certainly would love to be able to manipulate you, Michael. That is
it's actually not that hard. So, so can you maybe leave us? We're coming down to time here. Can you maybe leave us with a couple of specific examples of what that preventative care will look like, one-on-one or talking to a family, and ultimately what you expect will come out of that. I mean, obviously, fewer catastrophic cases and generally healthier population. But how do you get me there? How do you get me to? You can incentivize the physicians to take care of me preventively, but what are you gonna do with me?
Well, we need to reframe the way we think about things, right? If I were to think about right now, what is the best indicator of your healthcare outcomes? And if I were to ask people, people are gonna say obesity, cardiovascular risk factors, so on, so on. The reality is that is your zip code. It's not genetics, it's not obesity, it's just where you live. That is the easiest way to know what's gonna happen with your health. That's horrible, right? So you think about Spectrum Health and we're delivering care, we're 30% of your outcomes. Sure, when you live in a difficult area, you're exposed to pollutants, you have no access to good food, you have no access to good education, there's disparities, you have to work 3 jobs, so on. When you get that heart attack, here we are, and we'll do great at it. And we are really good at that. Well, now we need to think about how do we get you into a better house that is cheaper. Who do I partner? Who's good at housing? And how do I get people food? Who's good at delivering food? So we're working on those partnerships. This is not about Lipitor, it's about lettuce. And how do I get you that you have a good stock in your fridge of things that are nutritious? How do I help you secure some income so you lost your job and we're still at risk? How to make sure that you can pay the rent? How do you make sure that you can pay your debts? So now I have incentives that are very weird for us physicians to think about, and even for the population, it's well, why would you be investing in that? Well, that's
reaching out.
In that role, are they trusting of us in that role? They usually aren't trusting of insurance companies in that role. They're semi-trusting of healthcare. They're more trusting of their public, and they're certainly more trusting of their community. So I think, as Alejandro mentioned, partnering with folks that already know how to do it really well is the way to go, and how we can support that. This pandemic is just all about knowing the whole person and where they are, how I different from Alejandro, from you, Michael, how my situation is, my family is, my financial situation is. And so when you ask, it is going to be individualized and personal for that individual patient and what they need. And some people need a lot. They just need a lot of help, and others not so much. And we need to be able to recognize that as a healthcare system and not peanut butter spread how we do right now.
Great, thanks. We're out of time. One last question comes from somebody who's listening, and I think it's a question that every parent and every teacher in the country wants to know. So hedge your bets on this however you like. Would you send your kids back to school in the fall?
Yeah, I plan to send my kids back to school if there is school. I likely will enforce masking for them. It's interesting because they're still in Michigan right now, and we're moving to Cleveland. So I'm learning the ways different states are dealing with schooling. My plan is, if school is open, to send them to school, and my kids are 10 or less. So
thanks.
It's a very difficult question, and I think my personal decision about what's going to happen with healthcare systems for PPE. So add another layer to this. That's another symptom that we're like, definitely, we need to have better alignment. A very difficult question. In our family, we have had an extensive dialogue. We do plan to send my daughter to school, but she goes to a great school that is actually quite small, and we have been allowed to have an open dialogue with the school administration, and we understand exactly what they're doing. But not everybody might be as privileged, so it's a tough question. And I also, Michael, I saw in the chat a question about if the spectrum help people, like how many employees got sick, and I can we've been quite.
Great to see you. Really appreciate it. I hope to see you again soon.
Thank you for having us.
Good luck as you continue to face this now. Appreciate it.
Thank you.
Thanks.